And thank you for the invitation, Dr. Chintaka and Meranti and the faculty of Colombo North Center for Liver Disease. All right. So, we are all coming out of pandemic. I would have loved to be present there and give a talk in presence of everyone, but because of the pandemic, I am now, I'll have to give the talk online. So there is nothing, no potential disclosures, no conflict of interest. Dr. Chintaka had requested me to talk briefly about my hospital. So Tata Memorial Hospital, it is a grant in aid institute. It's under the Department of Atomic Energy, Government of India. The mandate of our hospital is to treat only oncology patients. So the file is registered if and only if the patient has a proven malignancy or a suspected malignancy. We have a 700 plus bed facility. It's a tertiary care center. And not only it caters to Indian population, but also to Asia, Middle East, and African countries. We have an annual new cases of cancer of the 65,000 annually, and follow-up cases which account to 450,000 annually. We also have a dedicated research facility 25 kilometers from the main center of Mumbai. And because there has been severe shortage of onco care in the across India, 7 new hospitals have come up under the flagship of TMC, and the working pattern, everything would be very similar to what we practice at Mumbai hospital. Talking something specific to my department. So we have CM DSA machines for doing vascular and non-vascular procedures. We have a dedicated CT scan, which is used for biopsies and minor CT-guided interventions. We have a state-of-the-art hybrid CT DSA, that is on one table, we have got C-arm as well as the on-the-rail CT scan, so that we can do complex procedure. In fact, this was the first of its installation in India. Apart from this equipments, we have dedicated ablation equipment. So we have the RFA equipment, we have microwave ablation equipment. Recently, cryoablation also has been added. And we have started even IRE, that is irreversible electroporation services also. And we have got license for the treatment of treating using radioembolization. I mean, our hospital would be unique in the sense, apart from this dedicated equipments, we also have got anesthesia procedures that are scheduled for all the 5 days of the week. And we have dedicated anesthetist also to cover the complex procedures that would require IR involvement. So this is our setup. This would be the ablation setup. We have the RF equipment, the microwave. This is the cryo equipment and the IR equipment. All the patients that come to our to the hospital, they are irrespective of the site, be it head and neck or lung or esophagus or liver, it's all managed by the multidisciplinary tumor board. That's we have MDT, and the decision is patient centric, and it's taken by the MDT clinic. So this is our pre-COVID photograph of the liver clinic, which where you can see that there is involvement of the surgeons, the medical oncologists, the hepatologists, the radiation oncologists. Of course, we play both the role of the diagnostic radiologist as well as the IR and give feedback as required. Now, coming to the topic of today of interest, that is the liver-directed therapies in malignant liver disease. I would be covering basically the vascular and the non-vascular, and among the vascular, the arterial interventions and the portal interventions. Non-vascular, predominantly, I would be concentrating on the ablative therapies. So now, why is transarterial treatment feasible in liver? Like there are many organs for which the chemotherapy is given, and essentially that would be systemic chemotherapy that is given IV. So what is so special about liver where transarterial is feasible? So the reason is the dual blood supply to the liver. So we all know that the liver has got supply from the portal vein as well as the hepatic artery. Normal parenchyma receives a blood supply from the portal vein. The 80% of the blood supply is from portal vein, while 20% is from the hepatic artery. Whereas when it comes to the liver lesion, the malignant lesions, the ratio is reversed. That is 80% of the liver tumor derives its blood supply from hepatic artery. You can see here, as the disease becomes from benign to malignant, from low grade, high grade to malignancy, the hepatic artery supply goes on increasing and the portal venous supply reduces. So that's the reason why if you inject something into the hepatic artery, it would preferentially go to the tumor, and very less of the infusion would go to the normal liver parenchyma. So there will be a large dose within the tumor and very less dose that would go to a normal liver parenchyma. So this is the basic basis for the treatment by transarterial route. Now there are few terminologies which we need to be familiar with. So there, one is transarterial embolization. Embolization essentially means cutting off the blood supply. So you block the blood supply that is being supplied to the tumor. So that is just called an embolization. Next is transarterial chemo infusion. So as the name suggests, you are just going inside and through the artery, used by the arterial route, you are infusing chemotherapy. So this is your simple, what you give by IV route, you give it by intra-arterial route. There is not much of application of chemo infusion in HCC. There is very limited area where you do this TACI. Next is transarterial chemo embolization. So this is a combination of the above two. So what we first do is we do chemo infusion, inject chemotherapeutic drug, and follow it with the embolization. We block the artery. So that is why it's called chemo embolization. And the last one is radioembolization. This is a misnomer, but actually we put beads which would emit radiation to the tumor. So that is what is called transarterial radioembolization, or also SIRT, selective internal radiotherapy. So essentially I would be concentrating on TACE and TARE. So either for TACE or TARE, the common indication would be a primary liver cancers, among which worldwide and including India, the common transarterial or TACE is performed for hepatocellular carcinoma, and in pediatric age group it is also performed for hepatoblastoma at our center. And next is the common malignancy is the metastasis from colorectal primary and neuroendocrine tumors. So essentially HCC, colorectal liver tumors, and metastatic neuroendocrine tumors to the liver. These are the they form the bulk for transarterial treatment. Contraindication, it would be either related to chemotherapy, that is severe thrombocytopenia or leukopenia, angiography related if the bleeding profile is deranged, or severe renal failure, or limited hepatic reserve, which we do see in the patients who are receiving chemotherapy, or cirrhotic patients where they are at risk for decompensation. So that would be another contraindication. So what essentially the transarterial treatment does, it gives high dose of chemotherapy to the tumor as compared to IV chemotherapy. It has a controlled and sustained release of chemotherapeutic drug, because you are infusing chemotherapy and also blocking the blood supply, so that the chemotherapy washout is minimal. Because the chemotherapy washout is very less or gradual, it goes into systemic circulation, the toxicity, systemic toxicity is also considerably less. And what are we achieving by doing transarterial treatment? Essentially, if the patient is not amenable for surgery initially, then we can downsize the patient so that it becomes amenable for surgical treatment, be it resection or be it transplant. If it is unresectable, then essentially we would prefer by transarterial treatment, we would stabilize the disease so that the patient has got a good survival, which was proven way back in 2002 by Lovett et al. In a randomized controlled trial, where it was shown that TACE prolonged survival as compared to supportive therapy. Now, the first topic that I mentioned was transarterial embolization. It is also called bland embolization. That is, you don't put anything except the embolizing material. Most of the time, the indication would be ruptured liver tumors, or the embolization of benign liver tumors like the hemangioma or the adenomas. Metastatic neuroendocrine tumor, if they are symptomatic because of the carcinoid syndrome, then again it would be essentially bland embolization, since it is a grade 1 tumor and very slow growing, we don't have to put a chemotherapy in this patient. Now, the embolizing agent that's used is essentially polyvinyl alcohol or gel foam. Sorry. So, what are the patients who are feasible for the treatment by transarterial route? That is, the guidelines have pretty clear for HCC. So we follow the BCLC classification for the treatment of HCC, and those patients who are feasible for TACE are essentially the intermediate stage HCC. The intermediate stage essentially is more than 3 nodules, which are more than 3 centimeter in size. So this is the intermediate stage HCC. Apart from that, we can also treat some early or very early stage HCC if they are not amenable for ablation or resection or transplant. So these are also the patient who can be treated by TACE. Now, for TACE, like I mentioned, essentially it is used for as a bridge to transplant or to downsize for a curative treatment that is RFA. And around 60 to 65% of the patients who come to TMH are treated by conventional TACE, while around 30 to 40% are treated by DEB TACE. Now, what is this conventional TACE and DEB TACE? We require a carrier for the chemotherapeutic agent to reach the tumor. So the carrier, depending upon what we use, it's either a conventional TACE, where you can see this is the lipiodol. On one side is the lipiodol. So when we are using lipiodol as a carrier, it is called as conventional TACE. On one side is a doxorubicin, on the other side is lipiodol. So we mix it so that it forms an emulsion, and that emulsion is slowly injected into the tumor feeding artery. So as compared to this, and following, once the chemo lipiodol emulsion is injected, subsequently the artery is blocked by using PVA particles or gel foam. So instead of using lipiodol emulsion and embolizing particle, if we use a specialized bead, which is called drug-eluting bead, it is called as DEB TACE. So essentially what this drug-eluting bead does is that it will capture either the doxorubicin medicine, chemotherapeutic agent, or irinotecan therapeutic agent in between the electrical charges, so that is released very slowly over a period of time. So when we mix the drug-eluting beads with doxorubicin, essentially we would be treating HCC. And when we mix irinotecan with the drug-eluting beads, it would be essentially for a colorectal liver metastasis. Now, there was a study that was done to see the pharmacokinetics comparing the conventional TACE and DEB TACE. Both are chemo embolization and both claim to retain the chemotherapeutic agent within the tumor as long as possible. But when this pharmacokinetic study was done, it was seen that conventional TACE, despite embolizing after the injection, there is a rapid peaking of the doxorubicin as compared to the DEB TACE. And this rapid peak is the one which is responsible for the systemic toxicity. So which essentially is quite, you can see that it would, you can expect this to be quite less in DEB TACE. So this is how the procedure is done, essentially by transarterial, transfemoral route or transradial route. We reach the celiac artery, we take the run, we identify the hepatic arteries, then we selectively cannulate the hepatic artery to reach the tumor feeding vessel. And once we are in place, we inject the emulsion. So we inject the chemotherapeutic agent. Basically, in this case, what we're injecting is the emulsion of lipiodol and doxorubicin. In the same way, using the same technique, we can alternatively inject drug-eluting beads. So this is in short how the procedure is done. And this is an example. You can see there are two lesions that are enhancing in the arterial phase, and which is corresponding angio picture. And post procedure, we can see that there is good uptake of the lipiodol within the lesion. Now, the reason why there is lipiodol uptake specifically in the tumor, because when we inject, there are chances that the lipiodol would go to the normal parenchyma also. But then when you take the CT scan after 2 weeks, you will see that the deposition is retained only by the tumor. This is because the HCC or the tumors, they don't have Kupffer cells. So the normal parenchyma has got Kupffer cells, which metabolizes the lipiodol, whereas the tumor cell which lacks Kupffer cells, they cannot metabolize the lipidol, and that's the reason why lipidol stays inside the tumor for a longer time. So inside this lipidol is doxorubicin, and that's the reason, that's the concept wherein the doxorubicin also would act on the tumor for a very long time. So this is another example, heterogeneously enhancing lesion in the arterial phase with the washout in the venous phase. We have done a test. We can see that it is very well seen of iodine content, and that's the reason why it appears hyperdense on the CT scan. Now, the deposition again can be very different depending upon the size and the blood distribution inside the tumor. You can see here that one area that the distribution is quite good, but then there is very heterogeneous elsewhere. So, in order to find out whether there is viability of the tumor inside this area which is not well deposited, it would be difficult on a CT scan. So that's why when we do conventional tests, they follow up this with MRI. So when we do MRI, you can see here that there is lipidol deposit. However, it is very well suppressed on MRI, because of which the enhancing component can be well visualized. So the follow-up for in conventional tests at our setup is essentially MRI. As compared to that, on depth tests, we do not inject anything that is very high density. So when it causes necrosis, essentially you can see it as a hypodense area, as you see here. But if you see the both, there is a large area of necrosis, but the size essentially remains the same. So this is a drawback of if you are using a RECIST criteria. So Dr. Lencioni and Lovett in 2010, they published a new criteria that should be followed for assessing the response of HCC after liver directed or transarterial treatment. So that is called as modified RECIST. That is, you can see it's MRECIST. Here essentially instead of measuring the entire lesion, only that part which is enhancing in the arterial phase is to be considered for as the size of the lesion. So it's not the entire size of the lesion, it is the longest enhancing component of the lesion in the arterial phase that has to be considered. So this is a case, you can see there is a large tumor post necrosis. There is some areas that is showing enhancement, essentially a partial response, but we can also see that there is a new lesion that has come up. And with the second session of depth test, you can see that the smaller lesion shows complete response. There is no enhancement of the lesion. And again, here in the larger index lesion also, there is significant reduction in the internal arterially enhancing component. As compared to HCC, CRLM, that is the colorectal liver metastasis, essentially shows reduction in both size and number of lesions after Debye test. As you can see here, there are large lesions which has reduced and in size as well as vascularity. Now the adverse events, most common that we see is the post-embolization syndrome. That is, the patient complain of low-grade fever, nausea, and pain. It is there for a couple of days. It's very rare that the patient or this post-embolization syndrome persists beyond 3 days. But once in a while, we do get patients who have got PES for almost a week or two. Again, liver abscess is also not a common complication, but if you do taste in a setup where there is a bilioenteric anastomosis, as in case of the post hepatic osteogeneostomy, or the patient has got an indwelling biliary stent, the chances of liver abscess significantly increases. This is a publication by the IR Society of Europe, which is the CERSI guidelines, which they have evaluated, done a meta-analysis, and they have shown that the chances of complications by TACE is significantly less. You can see that most of them are less than 1%. Even the hepatic complication are also significantly less. There was a randomized study done and published in 2010, which is called a Precision Phi Study, where they compared head-to-head the conventional TACE and depth TACE, assuming that depth TACE would be superior compared to conventional TACE. However, the result showed that the objective response and the survival were essentially the same, be it C test or depth test. The only thing which was statistically significant was the patient, the side effects were far less as compared to the conventional test. This was another interesting publication in British Journal of Surgery, where they tested whether a new adjuvant TACE would benefit the patient, and they concluded that response to, if the patient was a TACE responder, where it showed response to TACE, he is likely to have a better overall survival as compared to those who are non-responders. So now moving on from TACE to TARE. So essentially, TARE, that is transarterial radioembolization, is a misnomer in the sense there is no actual embolization of the tumor. It is essentially beads which are carried, which are having a radiation emitting beads which are injected into the hepatic artery, which gets deposited in the liver tumor and gives radiation. So anything that is more than 70 gray causes irreversible cellular damage to the liver. So that's the reason why when it was started in the 1950s, when external radiation was given, there was a very high rate of decompensation because even normal parenchyma were getting damaged easily. But like I told you, based on the principle of dual blood supply and specific supply to the hepatic to the tumor by the hepatic artery, when we inject these radiation beads, there again specifically going into the tumor, and the non-target embolization of normal liver parenchyma can be avoided. So in India, there are various radioembolization agent that is available. That are available. One is Yttrium 90. We have got two companies like you see here from the Surspheres and the Theraspiers. There are a few centers which are injecting iodine 131 labeled lipiodol, which are labeled with that. With iodine 131 and even rhenium 188. At our center, we essentially use the yttrium 90, and between the SIR and Theraspheres, we don't have any particular choice. Depending upon availability, that's what we are going to use. So like I was telling, this is the misnomer. In chemo embolization, we actually block the vessel, and then there is ischemia that is developing inside the tumor. As compared to that, in radioembolization, these beads penetrate into the tumor and over a period of time emit radiation, and that is how it controls the tumor. So this TARE is done as a two-step procedure. First step is in the planning angiography. So when we do a planning angiography, we need to be very sure that the angio architecture is very favorable for this procedure. So we do not want Y90 to go anywhere else except the liver, because wherever these beads reach, they would emit radiation in that particular area and cause the complication. So if it goes to the duodenal or the gastric vessel, there would be gastric ulceration and perforation. If it goes into the falciparum artery, which goes towards the umbilicus, again arising from the hepatic artery in some patients, it can cause skin necrosis around the umbilicus. Similarly, we would also want to know what is the shunting between the liver and the lung. So normally, in all of us, there is some amount of shunting which is present between the liver and the lung, which is called hepatopulmonary shunt. So if this shunt is more than 20%, that would essentially again be a contraindication for TARE, because more than 20% of the dose, if it reaches the lung, the patient is at risk for developing radiation pneumonitis. So as a part of the planning angiography, we also calculate the volume of the tumor that needs to be treated in the setting, and accordingly we calculate the dose and order the Y90 agent. So in the second step, we coil the collateral vessel. So whatever vessel which would be taking Y90 away from the artery into for a non-target area, we would embolize that and then subsequently proceed with the TARE per se. So this is where we take a cone beam CT or a 3D CT at the time of angiography, and all the tumor is calculated. This is the tumor CT volumetry. And then on the day of the procedure, we embolize the collateral artery. So a GDA the right gastric artery, all these arteries, and this is the falciparum artery that is coming from the left hepatic. So all these arteries, which would essentially result in non-target embolization, these are coiled. And this is the setup of the tear. You can see that the inside this perplex glass is the lead shield, which has got the Y90 loaded in that, and which is infused slowly. So the response assessment, again, this it can be using CT scan or MRI. And like I mentioned, we use the M-RECIST criteria to see the amount of reduction in the enhancement in the arterial phase. In TARE, we also can see some amount of reduction in size. As you can see here, the initial volume was 930, and post TARE, after 6 weeks, you can see that it has reduced to 250. So another example where before TARE, you can see that's a large lesion which is showing heterogeneous enhancement, and post TARE after 3 months, you can see there is not only reduction in the size, but also significant reduction in the enhancement. So the literature says that the ideal time for response assessment after TARE is 3 months, because if you do it in 6 weeks, it can show pseudo progression because the inflammation induced by the radiation itself. So the ideal time to see a response after TARE is 3 months. So not only the parenchyma, even the tumor thrombus also shows response after TARE. Here you can see that essentially the patient has got a tumor. This is the primary, which with extension into the portal vein, and in the arterial phase, we can see that it is enhancing, and in the portal phase, it shows washout. So that is washout in the venous phase and enhancement in the arterial phase, suggesting tumor thrombus. And after TARE, you can see that even in the arterial phase also, there is not much of enhancement seen within the thrombus. So this is response, a good response of the tumor thrombus after 3 months of TARE. Like I mentioned, the complications of TARE is extremely rare because you do not inject any chemotherapy and you don't embolize. So you don't expect major complication for following TARE. These are just representative images which can go wrong if the proper care is not taken. Here, this is a radiation pneumonitis which resulted because of high dose of radiation reaching the lung. Because of despite 20%, if the hepatopulmonary shunt is more than 20% and the dose is not adjusted, this is a likely complication. And this perhaps one of the artery was not coiled, and the catheter and the Y90 drug would have reached the stomach through some vessel, causing radiation gastritis. So we, in the last 1 decade, we have treated around 120 patients, and our objective response that was seen was around 70%, pretty much same as to what was seen in the Western countries. And when we looked at the survival, again, the median overall survival in our setup of patients was around 16.3 months. For a BCLC-B, that is without the portal vein involvement, it was around 19 months, and median survival for BCLC-B-C, that is those who had portal vein thrombosis, was around 9 months. So now we have got TACE and TARE. So what is the benefit of TARE? Like I mentioned, there is no embolization and no chemotherapy. So we can expect that the toxicity is going to be significantly less, because of which the procedure can be done on the outpatient basis, and it has got definite indication in portal vein thrombosis. So like I mentioned in the beginning, normal parenchyma, the blood supply depends upon the portal vein. 80% of the supply is on portal vein. So if portal vein is thrombosed, then the normal parenchyma is dependent on hepatic artery for its nutrition and perfusion. So if at all, if we do TACE, where we give chemotherapy and follow it with embolization, effectively we are knocking out both the blood supply. The portal vein is thrombosed, and we would also be knocking off the arterial supply, which can result in massive hepatic dysfunction, decompensation, and hepatic failure. So the indication for radioembolization in HCC is definitely when a portal vein thrombosis is present. So it has also been used as a bridge to transplant, and it's also used prior to surgery as a new adjuvant. And when the initial data came, it did mention that it has got promising survival data as compared to TACE. But then subsequently, there were many publications and even meta-analysis failed to show that there is any survival benefit between TACE and TARE when you treat an intermediate category HCC. So if it's a portal vein thrombosis that is present, that is the advanced HCC, definitely there is TARE has a role. But in an intermediate category HCC, there is no significant difference in the efficacy between TACE and TARE. So again, this is the meta-analysis of all the randomized trial comparing TACE and TARE, which mentions that TARE and TACE provide similar outcomes in unresectable HCC. So this was an interesting article, in one of the learning resource of ASLD, that's American Association for the Study of Liver Disease. The two articles, one both by the medical gastroenterologist, one supporting TACE for unresectable HCC and the other one supporting TARE. So those supporting TACE mentioned that there is evidence which supports that TACE is good in HCC. While comparing to TACE, again, there is no overall survival, but TACE is more cost effective. So basically, this author was promoting TACE because the TACE was more cost effective. As compared to this argument, that by the those favoring TARE, you can see they have given the list. It has got a wide range of applications, which includes more advanced liver disease. That is, even if the patient has got a child PUG score of B8, you can still use it in case of for TARE, but you cannot do TACE in such patients. In a multifocal disease, again, TARE is better because the post-embolization syndrome would be less. In case of vascular invasion, we have already discussed, so also the case of portal vein thrombosis. So definitely there is a spectrum where TARE would benefit more, would benefit better as compared to TACE, even if there is not going to be a overall survival benefit. So the quality of life matrix and toxicity profile was much better compared in TARE as compared to TACE. So just to sum up, this was the guideline that is in the European guidelines, that is the CERSI Society says that multinodular HCC, which is more than 5 centimeter or invading the portal vein branch, it is better to do TARE. And whenever there is a very high lung shunt fraction that is seen, it is better to do TACE if there is no if there is no portal vein thrombosis. So the smaller the lesion, smaller the number, its TACE is fine. But larger the size, larger the number, or portal vein thrombosis, TARE is the better option. So there is a new concept called radiation segmentectomy, wherein you give a very high dose of radiation to one particular segment which is carrying the tumor. So essentially, this is used for treating early hepatocellular carcinoma. This was published in 2018, where HCC less than 5 centimeter were given radiation of more than 190 grays, and we can see that the overall the survival was much better, and it was comparable for ablation. So the 1, 3, and 5 year survival for lesion which is less than 3 centimeter was 100, 82, and 75 again, which matches with the ablation or surgical resection. What about colorectal malignancy? So all this was regarding TARE, role of TARE in HCC. So where does TARE stand for colorectal malignancy? So we had a very recently a multiple trial in the last decade where Foxfire, Surflox, and Foxfire Global. Now there's a publication analyzing all these three randomized phase 3 trials in Lancet Oncology, which clearly mentions that there is no role for TARE or SIRT in the initial part of the treatment. So combining it with chemotherapy or giving it in the place of chemotherapy has got no role. So the ESMO framed the guideline telling that radioembolization has a role only in those situations where it is liver limited and failed chemotherapy. So if a patient on colorectal has failed the medical management by systemic chemotherapy, only in such situation we can consider radioembolization as a rescue. So now moving on to tumor ablation. So it can be tumor ablation are of two types, either thermal ablation or non-thermal. So in thermal, again, it can be because of hyperthermia, which is RFA, microwave, laser, or HIFU, or it could be hypothermic, or where the temperature, where the cells are frozen, which is called cryoablation. And non-thermal ablation essentially is chemical ablation or IRE. Chemical ablation is we use ethanol or acetic acid, and at our center we do not use chemical ablation for any treatment. So I'll be essentially concentrating on radiofrequency ablation and microwave ablation. So this is a publication by Lencioni, which clearly told there were two Western study and Eastern study. The Western study concluded that there is no benefit, there is no significant difference between the RFA or percutaneous ethanol infusion. However, that studies done by the East very clearly showed that there is significant difference where RFA fared much better than ethanol ablation. So that's the reason why we do not practice ethanol at our center. We essentially use RFA or the microwave for treating liver tumors. The mechanism of action is completely different between the two. Definitely, microwave has got is much more faster. The temperature is much more, and the procedure time is much less. But where definitely the role of microwave is present is when the lesion is located close to a blood vessel. So whenever there is close to the blood vessel, there is a phenomenon called as heat sink effect. That is, the temperature is removed by the moving or the flowing blood, and the temperature is not sufficient enough to cause complete tumor necrosis. So whenever the lesion is located close to the blood vessel, microwave is a better option, because the temperature reached would be still higher as compared to RFA. So this is an example where you can see that the ablation was done close to the right hepatic vein, and in the follow-up there is a recurrence that has developed because of the heat sink effect. So this is our setup, which I already showed. This is the microwave. This is the microwave, and we have got two RF machines. The candidates for RFA, when it got a single 3 nodules up to 3 centimeter. These are the indications for HCC. And for colorectal and neuroendocrine metastasis, we can ablate up to 5 in number if the lesion size is less than 3 centimeter. The contraindication, again, if the location of the tumor is close to the main biliary duct, then the heat can damage the bile duct, resulting in stricture, and it is one of the contraindication. Anterior exophytic location can cause tumor rupture or seeding of the tumor along the tract. Again, it is contraindicated. And like one of the relative contraindication is biliary enteric anastomosis, because it can cause liver abscess. There are various modalities that are available for targeting the lesion. It can be ultrasound or CT scan, or combination of ultrasound and CT scan to target the lesion and see how the ablation is going on. I mentioned about the hybrid machine that we have. So we can use the fluoroscopy to reach the lesion if it is visible, and you can see there is a lipid deposit suggesting the tumor. So intraoperative ultrasound RFA also is performed, but it is very unusual to do the same for HCC. But for colorectal metastasis, we do get a call for ablating the tumor, which can be done intraoperatively under ultrasound guidance. This is just a brief summary. In between the last 4 years, between 14 to 2017, we had 774 ablation, out of which 58% of that, more than 50% was liver, of which around 60% of the ablations were done by RFA, and remaining around 40% was done by microwave. This is a case where we are using both ultrasound and a CT scan to target the lesion. Here you can see the lesion that is present in between the veins, and you can very well imagine that we use the microwave to target the lesion. So we use the CT guide also to confirm, and this is the final post-ablation CT scan. You can see that there is a faint margin of the lesion, and around that you have got a good margin. So this margin of 1 centimeter all around the tumor is extremely important. What the surgeons call R0 resection, we call it as A0 ablation. And having good margin is very important for the to prevent local recurrence and to improve the survival. So when it is HCC, we normally combine it with TACE. So we use a conventional TACE so that the lesion is opacified, and then we target that lipidol very easily under CT guidance or fluoroscopy guidance. And this is the follow-up of such patient after 3 months. You can see there is no arterial enhancement. Another similar case, after resection, patient developed a new HCC nodule, which was targeted by doing RFA. Again, you can see the zone of ablation as compared to the pre-ablation CT scan. It is a big zone that has developed. A complication rate, again, this particular analysis done by the Lencioni shows 3 separate multicenter surveys were analyzed, and the mortality rate was less than 1% after RFA. Major complication rate was less than 3%, and minor complication less than 10%. So this is pretty much the global standard, which even we also are able to achieve. So those intervention IR guys who are interested to read about thermoprotection at the time of ablation can go through this very interesting article published in CVIR in 2019, where various techniques were used to protect the organs like the stomach, the gallbladder, the colon, the liver, the diaphragm and lung at the time of ablation. One of the uncommon but yes known complication is bleeding. You can see that here post RFA there is the injury to one of the branch of the hepatic artery, and we can see a pseudoaneurysm and extravasation which can be immediately embolized and the bleeding can be controlled. The mortality because of bleeding is not much, but this is another known complication, the grounding pad burn, which is practically not present when you are using microwave because there is no grounding pad that is required for microwave ablation. So post-procedure follow-up, again, you do the blood workup, including the tumor marker, depending upon which histopathology we have treated. And it's very important, any imaging modality can be used, either CT scan or MRI, but it is very important to understand that post-ablation, the appearance of the lesion, how it appears. So if it's a smooth ring enhancement of the periphery, it is essentially benign. And if it's a heterogeneous enhancement in the periphery, it is suggestive of recurrence. So it's important that you look at the margin for understanding whether it is whether it is under control or whether there is recurrence. Quickly moving on to the portal vein intervention. So there is a concept called future liver remnant. That is which means that it is the volume of liver that would be left behind compared to the whole liver volume. So that is the remnant liver volume by the total functional liver volume. That is what is the FLR. And the normal FLR that is acceptable for surgery is around 20 to 30%. In pediatric 20, and adult without any cirrhosis 30%. If the patient has received chemotherapy or the patient is cirrhotic, around 40% of liver is required for survival. So we have got a software which can assess the volume of the FLR, which is called as a Miriam software, which we had validated at a TMH, and we found that it was quite accurate because the volume that was measured by Miriam, we compared it with the volume of the resected specimen, and it matched quite close. So what is portal vein embolization? Essentially, a PVE is blocking of the blood supply to one lobe of the liver, so that the blood flow is redirected to the other lobe, the normal lobe or the lobe which is going to be left behind. By redirecting this blood flow, the more nutrients reach this particular lobe, and it causes hypertrophy. By hypertrophy, the patient would be essentially become eligible for surgery. So there are various agents that can be used, and what we use is the N-butyl cyanoacrylate or the glue. So just a case, this is CRLM with who had come for resection of primary, and at the same time they had planned for resection of the liver tumor. Here you can see presence of liver metastasis, but the FLR in this patient, I'm sorry. But the FLR in this patient, you can note here that it is just 27%. Again, post-chemo liver, 27% is not ideal for resection. Patient underwent portal vein embolization. This dense material is the glue that we used. And the after FLR, after glue embolization, you can see that it is increased from 27% to 42%, and the patient underwent hepatectomy without any hepatic decompensation in the post-op period. So the treatment for any patient is always personalized. So it's not that the patient will have to receive only one particular treatment based on what is seen on imaging. Sometimes we'll have to combine the treatment for the best of the patient. So the most commonly done is at our center is the TACE plus ablation, TACE plus portal vein embolization. This is an example of a patient who had HCC of the right lobe, but the FLR was 29%, so not eligible for resection. And patient underwent portal vein embolization, and we always perform TACE at the time of along with portal vein embolization, or so that the tumor is under control. So we don't want the liver to hypertrophy, and at the same time the tumor also to the liver to hypertrophy and the tumor to increase in size. So we do TACE and followed by portal vein embolization. So this deposition, what you are seeing is lipiodol within the tumor, and this is the lipiodol and blue in the portal vein. So the FLR increased from 29 to 46%, and the patient underwent resection. And the final histopathology also showed that there was no residual viable HCC seen in the post-op specimen. So is there any evidence? Yes, there is. There's a publication in 2018 where a sequential TACE and portal vein embolization was done. And those patients who underwent TACE also along with portal vein embolization experienced significantly improved overall survival as compared to those patients who underwent portal vein embolization alone. So instead of combining TACE and portal vein embolization, this groups studied the role of radioembolization. So just with the radioembolization, not only they were able to achieve tumor control, but also they were able to achieve significant contralateral hypertrophy of the lobar lobe. So the radiation causes shrinkage of the lobe that is treated, and at the same time causes compensatory hypertrophy of the contralateral lobe. So this is one of the added application of TARE or SIRT. So the other application is combination treatment is TACE plus RFA. Here we can see there are this is what we commonly follow, and we have quite a few evidence suggesting that combining TACE along with RFA has got significant 1, 3, and 5-year survival rate without major complications. So even the meta-analysis published in KJR also supported that this combination of TACE and RFA is better as compared to RFA alone. Similarly, there was a publication recently in 2018 which studied combination of TACE and microwave. I was talking about RFA all till now. So TACE and RF microwave for a tumor up to 5 centimeter. So this is just an example of HCC, which we did TACE initially. And here is the example I was saying. This is normal parenchymal deposition of lipiodol. And after 2 weeks, when you see that the normal parenchymal deposition is gone, only liver, the tumor retains the lipiodol, which can be targeted easily. And you can see the ablation zone quite good. Even after 1 year follow-up, the disease is under control. Another example, HCC treated by TACE followed by microwave. And even at 3 years, the disease is under control. It has in fact reduced in size, and you can see the ablation margin also quite clearly. At times, you will have to combine TACE with the TARE whenever the TACE does not show response, as in this patient, which a large tumor. After one session also, there was not a significant, this one session of TACE done, not much of change in the size or enhancement. And subsequently, patient underwent radioembolization. And we can see that at 6 months, there is not only a reduction in the size, but also significant reduction in the enhancement. So this is combination of TACE and TARE. So I have pretty much completed all that was requested by Dr. Chintaka. I have covered arterial intervention, portal intervention, and even ablative techniques where ultra RFA, where microwave can be used. Now our department has got some collaborative project. Like I mentioned, we are developing an indigenous radiation emitting beads, which is called as Baba spears, because one of the drawback of SIRT or TARE is because the SIR spear or the Thera spear, they are imported. And in Indian rupees, I would say it would come close to 8 to 9 lakhs for treatment at TMH, which is a government center. So if the Baba spheres we are developing, which would be almost 1/10 of what the price of existing Y90 would be, we are in the process of validation. We are doing a study along with the surgery to see whether there is any role of pre-op embolization, because whether the embolization would result in reduced tumor cells in circulation at the time of surgery because of tumor handling, and whether it correlates with the recurrence at a later date. We are study going on with the radiation oncologist, where we are seeing the additive effect of SBRT along with TACE. And then even with the medical oncology department, we are involved in the Emerald 1 study to see the effect of durvalumab and bevacizumab along with TACE. So to conclude, Dr. Chintak, I would say this, this is the Indian National Association of Study of Liver guidelines, which we have borrowed from the BCLC. It's a modified BCLC. So essentially anything that is less than 2 centimeters, 3 nodules up to 3 centimeter, we can consider for ablation if the patient is not having any other comorbidities or contraindications for surgical treatment. Any the liver lesion which is more than more than 3 nodules or more than 3 centimeter in size, and the child Cook score is less than 7, then we can consider either TACE and TARE. And essentially, if there is a portal vein thrombosis, we would definitely go for radioembolization. So this is what I have just summarized what we follow at TMH. Smaller the size, we go for conventional TACE. As the size increases as it increases in size, the tumor, we go for depth TACE. And still bigger size or multifocal or portal vein thrombosis, we go for radioembolization. So apart from that, just this is my concluding slide. We also do non-hepatobiliary intervention in the department. So the most commonly performed one is the ophthalmic artery chemo infusion. This is for retinoblastoma. We have started doing thyroid RFA for recurrence after thyroid surgeries. Instead of mediastinoscopy, what we do is a EBUS guided FNA for mediastinal staging in case of lung carcinomas. For palliative tracheal stenting is done for patients who are having fractures. We do either acetabuloplasty or vertebroplasty depending upon where the cement is to be put. Percutaneous sclerotherapy is done for any lymphocyte post surgery or any venous malformation or hemangiomas. Lymphatic malformation is again exclusively done in our hospital to deal with the chyle leaks. And IR is something that we have very recently started for management of desmoid fiber tumors or fibromatosis and locally advanced pancreatic cancer. So I'd like to thank my colleagues from TMH, from the GIDMG, who has helped and always supported in our intervention. And this is again what Dr. Chintak had asked. This is our website, tmc.gov.in, and once you, and all these the institutes are those institutes which have come up now new in the last 3 years under the flagship of TMC. Where I work is TMH Mumbai and essentially ACTRAC, which is the research institute. We do have this one. There is a category in patient service. You can go to the International Patient Advisor, pro@tmc.gov.in, and international patients at tmc.gov.in. These are the two email ID where international patients can contact us for any queries. So thank you so much for giving me an opportunity to talk on our work, and I'm looking forward to the questions.